Okay, so look, I'm very pleased to have the opportunity to introduce Associate Professor Michael Nissen. Michael has over 30 years experience in clinical medicine, both in infectious diseases and pediatrics and in clinical laboratory microbiology, clinical lab microbiology, with particular interest in the epidemiology of vaccine preventable diseases and the diagnosis of infectious diseases in hospital, in public health and in industry settings. He recently took up the inaugural Director of Research at the Prince Charles role as at the Prince Charles Hospital in Brisbane. Prior to this, he was the Principal Medical Officer of the TGA and the Director of the Pharmacovigilance of COVID vaccines, with involvement in vaccine policy, strategy and governance as an ex officio member of ATAGI.
Thank you, Andrew, and thank you to the organising committee for this invitation. And also, I realise I'm the last speaker between you and the panel discussion where you get your chance to ask the really hard questions. But I just wanted to acknowledge country and the First Nations people and the lands on which we are meeting today. This is my conflict of interest, and I won't be talking about any regulatory or proprietary matters today. The important thing really, and I'm not here to tell you about what the recommended vaccines are. You're all very aware of that, and at the QASIS clinic, we tend to follow the guidelines of the Australian Immunisation Handbook. And in general, what I've done here, because I like this slide because it actually encompasses a lot of information. This is from the Melbourne Vaccine Education Centre of MCRI, and it splits nicely into the recommended vaccines following HST transplantation between those less than 10 and those greater than 10 years of age. And in general, there's not a lot of difference based on age. They tend to, children and adults tend to get very similar vaccines, except maybe for Gardasil 9 and recommendations around that use. And also then potentially when we start looking at live attenuated vaccines around varicella. Just importantly, with the COVID era, we're still recommending in terms of course, COVID-19 vaccination. And also we do have a choice in the availability of bivalent vaccines now. And of course, the recommendation that post-HSCT, that a new course or a full course of COVID-19 vaccines are administered. The other important point with the use of live attenuated vaccines now is that besides having measles, mumps, rubella vaccine, a recommendation, and the use of Avaravax following return of cell-mediated immunity, that we do have the option now with recombinant or inactivated herpes zoster vaccine. When we look at solid organ transplants, again, we will follow the ATAGI guidelines in the QASIS clinic, but also we rely upon guidelines from other sources, such as the American Society for Transplantation and the IDSA, or Infectious Disease Society of America guidelines that are published. They tend to have some very nice tables that I've borrowed or used here. And this does also give you some insights in terms of what vaccines should be considered before solid organ transplantation. And of course, from a North American setting, there are some vaccines here on this table that we would not routinely recommend in Australia, mainly because of epidemiology or risk, and this includes rabies, BCG. Smallpox is an interesting one with the advent now of monkeypox, and also the fact that we have access to an inactivated smallpox vaccine, or Genios, which we've been using in our clinic for at-risk individuals, but also this potentially will cross over into the transplant arena because some of these individuals will require either HSCT or solid organ transplant in the future. And we've been using either a combination of intradermal vaccine when vaccine supply was constrained, but we've returned to routine use of subcutaneous vaccine. The other important part of this slide really is in terms of the need for immunologic or serologic response following vaccination. And you can see it is recommended for hepatitis A and B, for tetanus, Hib, and then for HPV, rabies, and MMR. One of the I suppose, difficulties with transplantation, particularly solid organ transplants, once they are able to have MMR, is actually do they seroconvert? And certainly measles and mumps tend to have low rates of seroconversion. And therefore, one of, I suppose, the strategies that you can use if they remain inactivated is actually to ask the hematology laboratory in terms of what the OD readings are on their inactive samples, and actually store those and then use that in parallel and use your OD reading as a measure of actual potential seroconversion. And that's actually been quite useful in preventing repeat doses of MMR. Of course, with the success both of solid organ transplantation and HSCT, these individuals are now travelling more, and therefore the consideration is required to some of these travel vaccines, particularly for vaccines in high-risk areas, and include yellow fever, Japanese encephalitis, salmonella, where there is a limited supply at the moment of cholera vaccines, so it does not tend to be used for travellers' diarrhoea, and we have very little access to that to prevent toxigenic E. coli. The other important I suppose consideration is when we go to all this trouble around the able to move that. Sorry. Yes, sorry. Is actually how well are we doing? And certainly this is a very nice systematic review paper that looks at vaccine responses for the whole range of vaccines that we would tend to give in this cohort population. So if we're looking at influenza, and this is the range of studies that was reviewed in this publication, you can see that the seroconversion rate varies in the study, and it actually may be as low as 20 to 30%, but then again, maybe as high as 66%, depending on the study. And then if we look at seroprotection rates in terms of what their risk of flu is following, again, you can see various rates, some as low as 29%, 19%, depending on the study and how it was conducted. But it may be provide seroprotection up to in the low 90s. So this is interesting information, and you can use this again in some of your risk assessment sometimes, particularly during re-immunisation during winter months or travelling to at-risk areas. Again, this has been done for pneumococcal vaccine, and again, you can see varying responses in terms of overall seroconversion or seroconversion rates to particular serotypes of interest. And some of these serotypes tend to be problematic because of either low immunogenicity, such as 19F and 6B. But in the general population, in terms of invasive pediatric disease, serotypes we tend to worry about are 6A, 3, and 19A in terms of their risk of antibiotic resistance. If we look at seroprotection rates, again, you'll see a wide range of seroprotection for these different studies. And again, some of that is zeros in on particular serotypes or a particular type of vaccine, whether it's a conjugated PCV13 vaccine or the polysaccharide 23 vaccine. For diphtheria, or mainly pertussis, is what we tend to be interested in this country. Again, you can see in general fairly good seroconversion and seroprotection rates. Hepatitis B, again, will vary, and this was mainly used in terms of the dose or the antigen concentration that you're using, followed by Hib. Meningococcal vaccines in general are well tolerated with good seroprotection rates, depending again on the serogroup. No information on meningococcus B, unfortunately. And then for MMR and varicella zoster, for completeness sake. I suppose one of the really important things in terms of an update, as far as we're concerned here in Australia, is the PBC outcome from March, which finally meant that we now have access to the recombinant or inactivated HSV vaccine, which is called Shingrix. And you can see that immunocompromised cohorts are included in this, and excludes HCST, solid organs, hematologic malignancy, and advanced untreated HIV. And really, this recommendation was based on the evidence and the dossiers that they had at the time. They were certainly aware of other immunocompromised groups that would certainly benefit from that, and this includes rheumatologic conditions and other autoimmune disease. But at the time of the submission, the weight of evidence in terms of cost effectiveness was not available, or to a level that could determine that there was a cost benefit in that Australian population. So just looking a little bit more in depth in terms of the use of Shingrix in this population, is the immunocompromised group from 18 to 49 years of age. And this is a nice paper from 2020, I should say, that looks at this. And it looks at a whole range of studies that have been published, from stem cell transplants through solid organs, hematologic malignancies, and HIV. And you can see what the level of evidence and their quality ratings were. So in general, these studies were rated as a high level of evidence with good quality. So when we start looking at these studies, and for completeness sake, and I suppose because this is a very big, busy table, I've put on the left-hand column the cohort of patients that we're looking at. And certainly if we're looking at just HSCT patients, you can see what their humoral response was, and then their CMI response. Then going through the solid organs, hematologic malignancies, and then of course HIV. But if we're looking at humoral immunity, I've summarized for you in the right-hand column in terms of what the seroprotection rate is based on these good quality studies. If we look at efficacy, which is really, I suppose, the end game and the important aspect of this once these individuals are in the community, there's only really 2 studies. And in HSCT patients who received 2 doses, vaccine efficacy was estimated at 68%. And in the 18 to 49 group, it was 72%. In the post hoc survival analysis, in the first 2 years of follow-up, their risk of having an episode was 0.31, and after the first 2 years of follow-up, the hazard ratio was estimated at 0.79. So in summary, after 2 years of follow-up, there seemed to be no significant difference in clinical protection between the first herpes episode between vaccinated and placebo arms. So it may indicate that there is some clinical protection for about 2 in the first 2 years, and then it tends to be waning. And I suppose this will be important in terms of whether boosters will be required in the future. There's one other study in hematologic malignancies, which I've listed here, with an efficacy following 2 doses of 87% up to 13 months post vaccination. So finally, it's not all about herpes zoster in this group. Certainly pneumococcal disease is actually quite important. And I just wanted to reorientate you to a study that we're actually doing through QOSIS at the moment, which the sponsor is MSD. It's called V116, and it's actually looking at risk populations, not in the transplant population, but those who have comorbidities such as diabetes, chronic renal, liver disease, chronic heart, or chronic respiratory conditions. And I use this slide really just to show you that not all pneumococcal vaccines are the same. Certainly, pediatricians are very aware of this in terms of the differences. But this shows you in detail what the different serotypes are. And traditionally, as a booster dose, we've used polysaccharide vaccine, and you can see the extra serotypes that were gained over PCV13. The uniqueness around this V16 study, and it actually has not been registered for use though, is that it has particular serotypes that are associated with either pneumococcal pneumonia in this risk group. So I think once this product tends to be registered, certainly there are other potential parallel studies and opportunities for the transplant population. And also just to remind you that we do have availability to a PCV15 now, which is part of the infant program, and also PCV20, which is just being registered, though not on the NIP use. So that's been a really rapid tour and update, but I hope you can appreciate that we're very happy to be available for any consultation around some of the difficult vaccination patients. We're based at the RBH, and again, we run a Monday to Friday service. Thank you.
Great, thanks so much. So that's great. It's clearly a it's still a rapidly evolving area, this revaccination.
And I should note, I didn't really want to include base studies really, because in some ways they're not in our arena and actually haven't got to that critical stage yet of either registration or NIP access. It's the most important aspect, particularly for us in Queensland, where we have to deal with arrogant list of approved medicines as well. So.
Thanks very much, Michael. Dan Chambers, lung transplant, Prince Charles. Just with respect to the herpes viruses, so just first of all, the first question is about Shingrix. So has that PBAC recommendation actually made its way through to a PBS reimbursement as yet? And if not, no. What's the time frame? You know,
it's been recommended, but the actual budget paper signing off on it actually have not occurred yet. So it isn't available to us in Queensland Health. As you probably know, there have been 2 submissions, I think, to the LAMP, Queensland List of Approved Medicines, prior to this recommendation, and it wasn't approved. Certainly, we already have a body of patients that we would love to give Shingrix to. And we're discussing if there are potential ways that we can give it to them now, because we realise that their risk is now and immediate and potentially not either in 3 to 6 months' time once the budget papers are finalised. So the simple answer is no, unfortunately.
And a bit of an unfair question needing a 30-second answer. Obviously, other herpes viruses are our biggest problem, and specifically CMV and EBV. Progress with respect to vaccines for CMV and EBV?
Certainly, look, there is a wealth is a wealth of studies, and certainly if you go just onto the clinicaltrials.gov website and you look in either CMV vaccine or EBV, you'll see somewhere between 30 to 50 studies, just the vaccines candidates alone, and that doesn't include things such as monoclonal antibody therapy or rather therapies such as immune T cells or using those type of strategies. So in some ways they are into the third stage sort of development. So in some ways we're at least probably 1 to 2 years away for us realistically.
My question in regards to Shingrix, if there's finding of the second vaccine with 2 to 6 months, has there been any strategy to have a look at our immunocompromised patient cohort to see whether if the second dose is given at the earlier phase and like 2 to 6 months?
Not to my knowledge, but certainly we do actually have someone from GSK here who might actually be able to answer that question probably in terms of using it earlier, in terms of, as you would say, in a so-called immunocompetent adult.
Oh, hi, my name's Tommy. I'm a MSL within the medical affairs team at GSK. So yes, according to the Australian Immunisation Handbook for immunocompromised patients, you can give that second dose at 1 to 2 months after the first. In terms of immunogenicity, I don't think there's a difference. Or is there? Sorry, can't comment.
So most of the studies have either been done using standard potential dosing in terms of 1 to 2 months following the first dose, or following what you would normally potentially do in your re-immunisation program, 1 to 6 months. It tends to fit in with that. So there is that potential to mix and match.
Right, wonderful. Thanks very much, Michael.